Good, good. So some birds missing from the formation, people missing from the crowd, the pathway itself missing. It's good to be able to pay close attention to clinical detail, and that's what we're going to try to do in cannula design and patient management today. This one is too easy for this audience. Spot the difference between the two interfaces, the high velocity therapy nasal cannula on the left and an occlusive positive pressure ventilation mask on the right. So the physical differences, as I said, are too easy for this audience. So what I really want to have you put in the chat, and I'll ask our panelists to comment on, is what are the clinical differences? What are the differences in these two interfaces mean for managing your patient? Dr. Whittle, Scott, feel free to throw out any ideas.
The glasses wearer, I noticed the one on the right is not putting glasses on.
Yeah, I think glasses are an important part. Oftentimes I have to provide some kinds of sedation or medication to help a patient tolerate if they're experiencing claustrophobia on the right side. So sometimes patients with the masks struggle more. They can also have more skin problems.
Good. Yeah, I think there are clinical significant differences, and you guys have picked up on some key factors. The patient can wear her glasses. Because her mouth isn't occluded, she can speak to her provider and her loved one. She can also drink fluids, take oral meds, that kind of thing. And as Dr. Whittle pointed out, just overall comfort, not the soft tissue trauma or physical discomfort from the mask.
Oh, in the chat, someone just put something very interesting. The mask doesn't allow secretions to be mobilized well. They can't cough. I think that's a really valuable point.
Excellent observation. Clearing and management of secretions, which is always cornerstone of these patients as well. Well, with those clinical differences in mind, that leads us into the objectives for today. We are going to discuss how the high flow and high velocity is affected by the internal diameter of the nasal cannula, the internal diameter. And we'll review the HYPERACT research study to understand the clinical effects of the high velocity, small bore internal diameter cannula. We'll understand the difference between small bore and large bore cannulas on respiratory rate and CO2 flush. We will review the high velocity therapy mechanisms of action. And our resident engineer, Scott Leonard, will be discussing a computational fluid dynamic modeling and providing us with a velocity demonstration utilizing an anemometer, a wind speed measurement device. It's my privilege to introduce today's discussants. We have with us Dr. Jessica Whittle, MD, PhD. Dr. Whittle is a full professor of emergency medicine at her university. She's also the chief medical officer for Vapotherm. By the way, she's one of only about 200 full professors who are female in the United States. So congratulate her on her groundbreaking career and tell all your daughters that they have a role model. Scott Leonard is our director of innovation and an engineer extraordinaire. Again, he'll be doing some of the deep dive into the cannula flow, airflow dynamics. And my name is Mike McQueen. I'm a 30-plus year career neonatologist. I'm a senior advisor to Vapotherm by way of disclosure. And I'll also be serving as the moderator today and doing a brief overview on the mechanisms of action. So we're going to start off with Dr. Whittle, who's going to give us a quick rationale behind and the study design for the HYPERACT trial. Dr. Whittle, take it away.
Yeah, so just briefly, I would like to mention my own story and how this happened. About 15 or 18 years ago, I began to work at a medium-sized hospital in the United States. It's a teaching hospital, about 450 beds. And I was working in a busy shift in the emergency department, and a patient came in who was clearly a COPD exacerbation, very small, slender man, tripoding and breathing very quickly, and a known history of COPD. And the respiratory therapist came and met me at the bedside, and I said, please go get a BiPAP machine. And the respiratory therapist said, can I use Vapotherm? And I said, I don't know, what's Vapotherm? And he said, oh, well, I'll work on this. And in the meanwhile, another patient was coming in on an ambulance stretcher receiving chest compressions. So I said, okay, you do your thing here, and I'm going to go take care of that patient, and I'll be right back. Well, about 30 minutes later, I came back, and the patient was lying back comfortably. He was speaking in full sentences. His saturations were excellent, and his work of breathing had significantly improved. He was still breathing quickly. I was still worried about him, but he had obviously been stabilized significantly. And I was so confused because that patient was only wearing a nasal cannula. I had always been taught that if you needed to help a patient remove the carbon dioxide and to ventilate, then you needed pressure to stint open the airways. That began a 15-year journey of trying to understand if there really is a different way we can assist patients in gas exchange. We did a study in around 2015 that looked at all patients with respiratory distress, and many of you are familiar with that data. And we were able to find that there were really no differences in intubation rates or failure rates for 72 hours for patients who came to the emergency department presenting with respiratory distress when we compared treating them with velocity-based therapy versus the mask-based. But what was interesting in that data is about 1/3 of those patients were hypercapnic instead of hypoxic. So they were type 2 respiratory failures. That then led to this trial where we said, if you have some patients, BiPAP works quite well when you're able to do it, especially if you're able to do it correctly. But it's so frequently challenged by patients who cannot tolerate the mask or patients who over time need to be able to eat and drink, all the things we discussed. And so this 1/3 of patients from our previous study were very interesting, and we decided to go ahead and say, let's do a randomized controlled trial looking at only type 2 respiratory distress patients. And that's what led to the study we're talking about today.
Thank you for that background, Dr. Whittle, and I think your experience is similar to what we've heard from many of our colleagues, is that they thought, how can a nasal cannula possibly do this? So I understand the question that the HYPERACT trial was trying to answer. Can you walk us through the study design?
Sure. So we decided, again, our hypothesis was that it was possible that some of these patients could be stabilized acutely with a nasal cannula and possibly even treated. And so the hypothesis is that patients presenting to emergency with acute respiratory distress thought to be hypercapnic in origin. Well, that was the most significant process occurring. Those patients could we treat and stabilize with a nasal cannula as opposed to mask. Go ahead and move to the next slide, and I'll show you what we did. So we had 7 hospitals in the United States, geographically different in size and different in their payer mix and patient population. And what we did was patients who presented to emergency with a chief complaint of shortness of breath, and the treating physician believed that the primary problem was a COPD exacerbation. We excluded patients who had a significant infiltrate on chest x-ray, high concern for a clinically significant pneumonia. We excluded patients who were severely hypoxic compared to their baseline, or those who believed to have heart failure as their most important diagnosis. We randomized the patients 1-to-1 to receive high velocity therapy or BiPAP. What you'll see on the slide is that the patients were screened, had to have a CO2 of 60 millimeters of mercury or higher with a pH of 7.0 to 7.35. So for our international colleagues, I believe 60 milligrams of mercury translates to about 7.5 kilopascals. So some of these patients were actually quite sick, and what we did was we decided our primary outcome would be relief of their chief complaint, relief of their breathlessness. So we measured them at 4 hours. We also measured their CO2, their pH, and their other vital signs and perception of comfort. So what you can see is that these patients on average had a quite high CO2 level, an average of 78 millimeters of mercury, or a pH of 7.27. So they were really quite sick with acute respiratory acidosis. So our outcome measure was, again, dyspnea. We were measuring dyspnea because clinically that's the most significant thing that we treat, particularly in the US. Meaning if a patient comes in and is feeling very breathless, then we'll continue to treat them, and we will we will measure their CO2 and all the other things that we typically measure. But the most important thing is if the patient is able to speak and continues to be comfortable. So that was our primary measure. And again, in addition, we measured oxygen saturation, respiration rate, all the vital signs that you would expect, as well as CO2 and pH. Next. Our initial therapy settings were 30 liters per minute with an oxygen FiO2 of 50% for the velocity base, or 12/6 centimeters of water pressure base. The clinicians were able to change those settings as rapidly as they felt that they should. The patients were treated according to whatever standard practice occurred at that hospital. Again, these were not substantially hypoxic patients usually, although some of them do use home oxygen. Usually it's at low levels, maybe 2 liters by nasal cannula or things like that. So we kept them at their lower oxygen level. Next.
Dr. Whittle, thank you for that. We'll get to the outcomes in just a second. I want to highlight a couple of the things in your trial design. To start with, I'm really impressed. These were sick patients, as you pointed out. The CO2's baseline was 78 in one group, 77 in the other group. This is truly a hypercapnic trial, which leads me to think that a lot of your investigators must have said, no way. There's no way that a nasal cannula is going to be able to treat severe hypercapnia. We've gotten comfortable during COVID using the device for hypoxemia, but there's no way a nasal cannula is going to be able to match up to positive pressure ventilation for this degree of hypercapnia. Did you encounter resistance from your investigators, or was everybody, able to buy into this trial and agree that the mechanisms of action that we're going to hear about provided a valid reason to give this a try?
Well, I think there's a growing body of evidence around the world that indicates some measure of hypercapnia can be treated through high-flow nasal cannulas in general. The investigators were most concerned because of the fact that we were wanting to enroll very severely hypercapnic. So it wasn't the idea in general, but it was the magnitude that we were suggesting. But our preliminary data suggested that with a small bore system, it was possible. We did have to include some safety measures in the study, and that being the chief being that the treating physician could stop the study at any time if they felt the patient was not responding. And I think we'll see the failure rates that so few of them did. It was really remarkable. So the treating physician could change therapy or could withdraw them from the study at any time, and that was a safety measure we agreed to from the beginning.
Great, thank you for that. What did it show?
Well, so again, our primary outcome was measuring dyspnea and relief of dyspnea. And what we found was that, just as we expected, for patients who can tolerate the mask, BiPAP does work. It relieves their work of breathing, and they feel better. Interestingly enough, so does the nasal cannula. So in this situation, for a small bore high flow system or a high velocity system, we met the criteria for statistical non-inferiority. So they work pretty equally. I think the more interesting is here on the next slide, where what we found is it statistically also was non-inferior, and they worked well for improving pH and improving the partial pressure of carbon dioxide over time. So what we see is that the CO2 and the pH tracked very similarly. And again, we know that BiPAP does work when it works. This is the same data, but gives you a more expansive view. And what we see is that the patients treated on the pressure-based therapy, actually the range widens over time. And I think this reflects what I see in clinical practice, which is that for the patients it works great, but for the patients it's not working, they actually can get worse or really struggle. Interestingly, the patients on the velocity-based therapy, the range narrowed, and they were more consistent in their response. That deserves further study to see if that's a pattern or a trend that will bear out in future studies, but it was an interesting observation. The only place that we saw a statistical difference between the two groups was when we asked them about their total level of distress or discomfort. So we very specifically asked the patients, not just about the mask or the interface, but overall, how much distress are you experiencing? And what we found was that the patients treated with the mask were first very distressed because they felt very breathless and very sick. But by the end, they were trading that distress for their irritation with the mask and the interface and the treatment itself. Some of them still felt quite ill, but they also experienced frustration. Patients with the nasal cannula steadily improved in their overall level of discomfort, and that was statistically different at every time point after the baseline. I do think it's important to note some limitations, Dr. McQueen, and you may have some additional ones. Our study was limited by all the things that any study of this type would be. It's impossible to blind the patients or the treating physician to what the interface was. These patients were emergency department patients, and so they could have a much more complicated medical picture than was immediately clear. But also, this is only a 4-hour study, and so while we believe we can infer that the ability to normalize their CO2 would continue, and they likely would have the same long-term benefits we would expect from other treatments. This is limited in time, it's limited in scope, but I think it's a really interesting study showing that, at least from a mechanism standpoint, it works quite well. We can blow off CO2 in a much more robust way than we may have previously expected through this interface.
Thank you very much for walking us through that. And again, I'm impressed by how sick the patients were. That said, from a safety standpoint, I also appreciate the fact that the physicians could switch therapies if they need to. And I know the patients were consented before they were enrolled in this trial. So despite those CO2s in the high 70s at baseline, and I saw your box and whiskers chart, some of the CO2s during the trial looked like they hit over 100, which was just remarkable.
So in the US trial, we had one patient with a CO2 of 119 and another with 120. That corresponds to 15.7 and 15.8 kilopascals. So they're really high CO2 levels. Now it is important to note that these patients were still awake, and our gear is indicated for patients who are spontaneously breathing. So they need to have a respiratory drive, and they need to be able to interface with you at least to that degree. We do not have it's not a mechanical ventilator where you can overtake their respiratory drive. But they were very sick, and each of those patients, one of those went to the velocity arm, and one happened to be in the pressure-based arm, and I can actually tell you both of them did very well and were able to complete the study and were treated effectively.
Impressive to hear. Thank you for that reminder that this therapy, like CPAP and BiPAP, is generally for spontaneously breathing patients. It's not a ventilator, nor does it pretend to be. Well, let's switch gears just a little bit, and I'm going to intervene briefly to talk about the mechanism of action to try to answer the question of how is this possible? How can a nasal cannula possibly provide equivalent support, relief of dyspnea? Really, I saw that happening within 30 minutes and then sustained over 4 hours. and removal of CO2 as well as a positive pressure mask. Well, the first thing I want to talk about briefly is just the difference between high velocity and high flow. Anna, do you have the hose slide, or is there I don't know if there's a graphic for this, or I'll just explain it. There you go. So yeah, the question I get fairly frequently from my colleagues is what exactly do you mean by high velocity? And I just want to remind you that flow is a volumetric measure of liters per minute flow. So it's a volumetric description per unit time. Velocity is a speed measure. It's distance per unit time, not velocity per unit, or not volume per unit time. So for example, on this graph, velocity is in meters per second. And so the analogy that we've come up with is to consider a simple garden hose. When you turn on a garden hose and hold it, say it's going at 30 liters per minute, that's a high flow device. The 30 liters per minute may or may not be accurate. I don't know what your garden hose puts out, but just for sake of argument, say that that's it. And that would be equivalent to a standard large bore high flow system. If you put your thumb over the end of the hose, note that you haven't changed the volumetric flow one iota. There's still 30 liters per minute going through the hose, but you've turned the water into a high velocity jet, a rapidly moving jet stream. And the same thing happens in the high velocity device. Because there is a narrow internal lumen, a small bore cannula, that's equivalent to putting your thumb over the end of the hose, and that forces that volumetric gas flow into a high velocity jet stream of air. And in fact, for any given volumetric flow, the high velocity device is going to generate a velocity that's 3 to 5 times that of the standard large bore device. So I think that's going to show up as clinically significant, and I wanted you to understand flow versus velocity for starters. So now let's apply that high velocity to the airway. And Anna, go back to the graphic that you had. Thank you. The two primary mechanisms of action of this high velocity therapy then are first a flush of the exhaled CO2 from the expiratory, or from the extrathoracic component of the respiratory dead space. Remember, the respiratory dead space has an extrathoracic component, that is the nasopharynx, the hypopharynx, the oropharynx, all of the airway space above the glottis, and an intrathoracic component, that is below the glottis, the trachea, the main stem bronchi, and some 16 generations of airways before you get to the alveolar spaces where gas exchange occurs. So during exhalation, this nasal cannula applied non-occlusively to the nares is going to use that high velocity gas flow to flush exhaled CO2 from the extrathoracic component. And essentially all of that CO2 is removed before the next inspiration. Because of the high velocity mechanism, it flushes the CO2 rapidly. So the patient isn't rebreathing the CO2. Also, because that's happening continually, breath after breath after breath, with the high velocity therapy applied, functionally that extrathoracic space, the nasopharynx, the hypopharynx, the oral cavity, is turned into a reservoir of ideally conditioned gas. Ideally conditioned meaning oxygenated to whatever degree you want, since the flow and FiO2 settings are independent of each other on the device. Also warmed and humidified, so it's comfortable for the patient and maintains mucociliary integrity because of the warmth and humidification. So when you decrease the dead space, you actually are offloading some of the work of breathing, a lot of the resistance. Anna, next slide. And that leads us to the simple physiology behind the therapy. I'm almost embarrassed to tell this well-educated crowd to remind you of the minute ventilation equation, but I'm going to do it anyway. You'll recall that it's tidal volume times respiratory rate. What we don't talk about as much is the alveolar minute ventilation equation, which is the same equation, Anna, carry on, which is the same equation but corrected for that respiratory dead space that we just discussed. So the tidal volume that's inspired minus the amount of that volume that's lost to that non-gas exchange dead space times the respiratory rate. And I love this equation because it actually highlights quite clearly the difference in high velocity therapy and positive pressure modalities, specifically, each one of those pulls a different lever on this alveolar minute ventilation equation. Anna? All of our positive pressure devices work by increasing inspired volume. And we've gotten quite good at titrating that volume. I just saw that there's a hand raise, and Anna, your discretion. I don't know if you want to interrupt for a question right now or save it for Q&A after.
Go ahead. To the folks with the hand raised, you should have the ability to unmute. Or put your question in the chat. For the sake of time, let's keep moving. But yeah,
we'll keep going. Okay.
Ability to unmute.
Yeah, save that. We'll get to your questions. We will have time for some Q&A at the end, so don't lose your spot. So again, looking at this ventilation equation, positive pressure works by increasing the inspired volume. High velocity therapy works by offloading CO2 and functionally decreasing the dead space. And as you look at this equation, you can see that if you have a 20% increase in inspired volume or a 20% decrease in dead space, either one, you have exactly the same impact on alveolar ventilation. So the unique thing of this high velocity therapy is that prior to this, we never had a mechanism to non-invasively functionally decrease this dead space. So no gimmicks, no tricks. This is based on just respiratory physiology, but it also explains why a simple nasal cannula can have the same impact as a positive pressure device in removing CO2 and affecting ventilation. Next slide. I also mentioned that the gas is ideally conditioned. The high velocity therapy, the vapotherm device, uses a water jacket insulation which surrounds the gas delivery system. If you look at the delivery tube and cut it and look at it in cross section, you'll see that there's a central lumen through which the breathing gas is delivered, and it's surrounded by a warm water jacket, an ingress and egress path of warm water. And that's important. It maintains that the delivered gas at a uniform, constant temperature throughout the respiratory cycle. This thermal imaging picture shows the uniformity of the temperature of the high velocity therapy gas. You see that on the right, from the device all the way to the bright red tip that interfaces with the cannula and therefore to the patient, the temperature is uniform. There are no temperature differences throughout the entire delivery tube. Contrast that to a standard high flow device on the left, which typically uses a heated wire tubing, which is fine. It does warm and humidify the gas, but you can see the heating coil within the tubing, and you can see differences in thermal imaging colors on the tube. Every place you see yellow between the bright orange coils is a drop in temperature, and anytime you have a temperature change, temperature gradient across humidified air, all of you know better than most what happens. You actually get rain out. Some of the humidification rains out and consolidates and enters the tube and is the constant hassle because your patient is going to be inspiring some of the rained out gas, rained out humidity. Okay, we're going to go into a deeper dive on some of the high velocity mechanisms, and that's where I turn it over to our engineer, Scott Leonard, who again is the Vapotherm Director of Innovation and Engineering. Scott, take it away.
Thank you, Dr. McQueen. So I want to start out by talking a little bit about computational fluid dynamics. This is a tool that we use as engineers to study fluid mechanics. There's no equations that define, the airflow over a wing of a race car or how an airplane stalls. There's not. You can't look at that and just solve an equation to come up with a solution. But there are equations that allow us to look at very small elements of flow and solve the equations for those. And the way that CFD works, computational fluid dynamics, is to break down these really big, complicated problems into very, very small elements, and then analyze each of those elements. We can solve those equations for each of those tiny elements. In some cases, 3 million little tiny elements that make up these complicated model that we're trying to solve. And so this is a tool that we can use to study something that is very difficult to measure otherwise. It's very hard to visualize the airflow, be able to measure the amount of carbon dioxide, for example, in an airway. So go ahead on to the next slide. So this is a tool that's been used in medical studies. This is an example from CHEST, where at the beginning of COVID, the researchers were looking at whether or not putting a mask over a patient's airway would be able to capture the particles that are coming out, the aerosol particles coming out of the patient's airway when they're using high velocity therapy, to be able to tell if it was safe to have this going on in a room, to be able to give this therapy and not put the caregivers at risk. And the result of the study showed that indeed the mask was able to capture. So this is something that has been used for very difficult to solve problems, very difficult to understand scenarios, and be able to shed some light on what's happening in those different problems. So we're going to take a look at a patient's upper airway. So you can see here, this is without any therapy. You're looking at a cross-section through the patient's airway, and we're representing, in this case, red is high CO2 gas. This is the gas being exhaled by the patient. Blue is representing low CO2, so that's the room air that you're seeing around the patient. So the closer to red it is, you're having up to 7% CO2 by mass fraction. And the gradient in between is indicating, something between 7% and 0%. So without any therapy on, we're looking at the peak of patient's exhale stages. When the flow rate is at its maximum, you see a lot of CO2 in the airway. That continues to increase up to the end exhale point, which is also where the most CO2 exists in the airway. You see the airway is almost completely flooded with high CO2 gas at that point. Now what's going to happen is as soon as the flow rate reverses and the patient starts to inhale that gas, all of that CO2 that's trapped in the airway is going to go right back into the patient's lungs, and it's going to increase the fraction of CO2 in the patient's lungs. It requires them to take a deeper breath in order to replace as much of that gas as possible with fresh air that's been perhaps oxygenated by the therapy. So moving on to a high flow cannula. So this would be conventional therapy with a large bore cannula, low velocity. We can see that at peak exhale, there's a lot less CO2 in the upper airway. It's actually holding back some of that CO2. At peak CO2, there's a lot of CO2 in the upper airway, but there's a little bit of area that is completely free of CO2. And then by end exhale, you can see that there's been enough time for the therapy to flush out a lot of the CO2 from the nasopharyngeal space. And there's still a little bit of CO2 left in there, but comparing end exhale without any therapy or with high flow cannula, you can see there's a big difference there. There's a lot less CO2 in the airway. Now we're going to move on to comparing the difference of velocity and flow. So both of these therapies are using the same flow rate. This is 35 liters per minute in this case. And you can see in the upper image, which is the high flow cannula, there's still some CO2 in the upper airway, at peak exhale and at the peak of CO2, and even at end exhale, there's still some CO2 in the airway. But when you introduce high velocity, at peak exhale, the CO2 is not really even entering into the nasopharyngeal space. It's exiting through the oral cavity. You can see the high CO2 concentration down in the mouth. Even at peak, the peak CO2 that we reach, there's a lot of CO2 in the mouth, but by end exhale, it's actually purged almost all of that out. You can see there's a big difference at end exhale between the amount of CO2 in the high velocity case and the low velocity case. But what's really interesting is the peak CO2. If you're able to prevent the CO2 from ever really entering the upper airway, then the patient with a very high respiratory rate, they don't have very much time at near end expiratory to flush the CO2. There's very little time remaining for that to occur. So preventing the CO2 from really entering the upper airway provides a big advantage in removal of CO2. So this is where the difference is the largest, and you see that if you have an increase in respiratory rate, there's less time to flush. There's a lot of advantage in flushing CO2 more rapidly. So this is the difference between, as Dr. McQueen said, putting your thumb over the hose. It flushes much more effectively, even with the same volume of flow. All right, so we're going to move on to a demonstration. This is pre-recorded, So I'm just going to set this up a little bit, and then we'll watch through the recording. But this is going to be a comparison between those two cannulas, the large bore and the small bore. And we're going to be using what's called an anemometer, which is a device for measuring wind speed. It won't give you the exact wind speed. Like I said, with CFD, you can measure these things that are very difficult to measure in the real world. Measuring velocity is very difficult, so this won't give the exact wind speed, but it will give you a very good relative comparison between the two. And we're going to be giving the wind speed in miles per hour in this video. So after each of those, I'll ask Anna to pause, and I'll give you the translation of what that is in meters per second for those who think in meters per second versus miles per hour.
So these are the two cannulas that we'll be testing today. We have the Vapotherm adult size cannula, and then for comparison, we're also going to use a larger bore cannula. We're aware that some of our clinicians are using different cannulas on the Vapotherm devices, and we want to make sure that you're aware of the differences that those can have, even when the flow settings are the same, that there's a difference in the velocity. So this is for educational purposes. We want to show that there is a difference between these and what that difference might be. To begin, we're going to test the Vapotherm cannula. So we have a position here with one of the nares pointed through the test section of the hot wire anemometer, and that's indicating a wind speed of 66 miles per hour. So that velocity,
so that wind 66 miles per hour, that's 30 meters per second. I should also mention, take note the flow rate is at 25 liters per minute right now. That'll be the same as both of these comparisons. So nothing is changing about the flow rate. It's just a difference in cannulas.
that's a very high number. That's one of the key features of our therapy. It's like putting your thumb over the end of a hose. You still have the same flow rate, but you have a higher velocity coming out, and that's what's going to be flushing the CO2 out of the airway. So now we're testing the large bore cannula, and you can see that we have the flow from one of the nares going through the test section of the hot wire anemometer, and we're reading out a speed of 25 miles per hour on the readout here.
That's about 11 meters per second. So comparing the previous one was 30 meters per second. Now with the larger bore cannula, we're down to 11 meters per second. So it's almost a threefold difference between the velocity of these two cannulas,
which is significantly lower than the 60 miles per hour that we saw with the Vapotherm cannula. So that lower velocity is going to result in less kinetic energy in the airway, less turbulence in the airway, which is going to reduce its capability of flushing CO2. So even though they're running the same flow rate of 25 liters per minute, there's a significant difference in their ability to flush CO2 from the airway, and that's why it's important to continue to use the Vapotherm cannulas when treating patients. So this is
all right. So I think that that really gives us a good demonstration of the practical difference between these two cannulas, and the CFD allows us to measure what the effect of that difference is, and then of course we also saw the studies that show the result of that and the outcomes. So really shows that there's just because the flow rate is the same, it doesn't mean that the flush or the removal of CO2 or the effect that you're going to get is identical between two different therapies. All right, back to you, Dr. McLean.
Scott, that's absolutely outstanding. I always love looking at your computer-generated graphics because I just find the images so convincing. It fits with the mechanism of action that we think is at work. It fits with the clinical outcomes. I want to connect a couple of dots. Scott, you were right to mention you don't have much time during the expiratory phase to clear that CO2. And so a wind speed of 30 meters per second compared to 11 meters per second absolutely is significant. Our physio colleagues on the line will they'll all make easy math. If a patient is breathing 60 times a minute, and assuming a 1-to-1 ID ratio, you have half a second to clear that extrathoracic dead space of CO2. So what I always tell my colleagues is if you want to scrub dirt off your car, you put your thumb over the end of the hose. If you want to scrub CO2 out of the extrathoracic dead space during the expiratory phase, you put your thumb over the end of the hose. Scott, thank you for that great demonstration. So the punchline, not all cannulas are the same. Here's another powers of observation slide where it seems that what you're looking at is more similar than different because you're comparing two nasal cannula systems. But thanks to that internal diameter, which isn't apparent necessarily when you're looking at the high velocity system, but Scott has showed you pretty clearly the difference in wind speed generated for any given flow. That wind speed is significantly higher in the high velocity therapy, which translates into that flushing mechanism of action, which translates into CO2 removal and and which translates clinically into resolution of hypercapnia and the dyspnea. Really, really important. I see a question that says to mention the importance of the temperature and the humidity. That's a really good observation, and it's a really good question. Thank you for bringing that up. I probably went through that a little bit too quickly, but the flows at 40 liters per minute, through the high velocity system, could even be with that wind speed. Again, Scott generated 30 meters per second at just 25 liters of flow. And so that's pretty high velocity when you're using the higher flows on the high velocity system. But because the gas is warm, because it's humidified, the patients actually find it quite comfortable. That humidification, by the way, is important because it maintains airway integrity. That is, if the gas is too dry, you actually get epithelial cell death. Before that, you get concretions that makes it difficult to remove the secretions. You can get decreased function of the mucociliary mechanisms. So the humidification is key, as is the temperature itself. Thank you for asking the question.
Hey, Mike, can I pop in right here? I was in...
Please do.
Thank you all for listening to me from a hotel room. I was in Wales yesterday meeting with some really brilliant physicians in the UK, and they had the same discussion about temperature and humidity. And I was wondering if this was only a US problem, but it seems to have more worldwide implications. One of the practical problems sometimes with a mask therapy in the United States is that even if you, as a clinician, order it or start it on a patient, oftentimes the BiPAP or CPAP is not humidified initially. And sometimes that patient won't receive humidity for that entire shift or through the night or until things are calmed down or they're in a more stable environment where the respiratory professionals can intervene and apply humidity. We know that you get mucosal damage in as little as 30 minutes. And so these patients who are going sometimes 4, 8 hours or more a day without humidity, we're really damaging their ability to clear their secretions. And in doing that, we know that if you damage those airways, you're actually causing a lot more inflammation, and it can really prolong their course. So I do think one of the mechanisms that the velocity therapy has that's so advantageous is from the very minute you turn it on, it's optimally humidified, and the patient immediately is experiencing therapy benefit from that, independent of anything else. I think sometimes we forget how important that can be because it's something we all know, but it's very difficult to practically do.
Yeah, outstanding. Thank you. And again, thanks for the question. Spot on. I do want to point out one other thing before I go to this summary. Go ahead, Anna, leave this slide up. But that's okay. This one is fine too. To achieve these mechanisms, that is the CO2 flush, and from the high velocity delivery system, you do need a non-occlusive interface. If you look very closely at the patient on the left, you'll see that the nares are not occluded. And in fact, a close-up view would show you that it's recommended that the nasal cannula occlude 50% or less of the nares. And it really doesn't matter if the patient's mouth is open or not, unlike a CPAP or positive pressure device. In fact, it could be an advantage for the patient to have their mouth open. And clinically, our colleagues tell us that at higher flows, the patient will sort of automatically open their mouth even without thinking about it. This provides a path of egress for that CO2 flush. So a non-occlusive, non-pressure-based interface, significant difference from the positive pressure devices. And that internal bore velocity versus flow is significantly different from the standard high flow devices. Anna, go ahead now to the summary slide. So thanks to Scott's demonstration of the velocity physics and understanding hopefully the mechanisms of action, and Dr. Whittle's presentation of clinical trial data, I think we can say that high velocity therapy is a reasonable alternative for patients with acute exacerbation of COPD who are hypercapnic, who present to the ED with respiratory distress. High velocity therapy supports ventilation by offloading exhaled CO2 and functionally reducing the dead space. and that there is a significant difference between standard large bore versus the small bore high velocity system in achieving these effects.
Hi all, thank you all for being here today. We're going to jump into some Q&A, but I just wanted to take a second to make sure you have some resources before we do that Q&A. So you can find your distributor with that QR code, and then my teammates will put that link in the chat here. We also have a hypercapnia resource center where you can learn more about Dr. Whittle's story, download a study overview, and there's a monitoring therapy white paper as well. And then the last resource I wanted to share is we love feedback, how we can improve, how we can help educate here further. So if you wouldn't mind, by completing the survey, you'll also get a certificate that you attended today. And so to get that certificate, you just complete the survey at btherm.com/0718 certificate. And my colleagues are going to be putting that in the chat as well. And we did get a question here. Will the patient get a lower oxygenation level if they are mouth breathers?
So really great question. It doesn't have a simple answer because it depends a little bit on how much they're breathing and how fast your flow rate and those things. But in general, in most circumstances, if patients are breathing at physiologically sort of normal levels, the speed of the gas is so quickly that most of what they will inhale will still go in through the cannula, and I would expect them to get fairly close to the same oxygenation level. However, I will say I have patients where what I really needed was to treat hypoxia, and actually if I can, I have them close their mouths and as much as possible so that all of the air going in is the oxygen-rich air. Opening mouth can be especially effective in a COPD patient with hypercapnia where you really want to maximize flush, but for the most part I find the patients will more or less get to just like a COPD patient will do pursed lip breathing naturally and reflexively. I find personally that most of my patients will reflexively put their mouth in whatever position is optimizing their reduction of work of breathing. So for most patients, I don't see a drop in oxygenation if they open their mouth. Scott, you may have more detailed opinion of that, but I would say except in extremes, it's not an issue.
Yeah, I think you're correct. Yeah, very, very high respiratory flow rates, then it would start to matter, I think. But at normal breathing rate, it's not so much of an effect. But yeah, if you want to optimize that, mouth flow breathing is going to give you a slight advantage.
Great question. Thanks, Vivian, and thanks for the responses here. For our next question, I want to ask the audience something. Would you, now that you've learned this study and understand a little bit more about computational fluid dynamics, would you consider trying high velocity therapy on a hypercapnic patient? So I'm going to launch this poll. We're curious what you think now. Are you willing to try it, or are you still unsure? And while you're completing that poll and answering these questions, my colleagues here, let's say someone's on the webinar and they do want to try it and they want to advocate for this more comfortable therapy. What do you recommend to help get physicians on board?
So interesting that you asked this, Anna. I again pointed out I had this discussion yesterday with some physicians, and this is what they asked. And I said, well, the first thing that I would tell you is be really aware of which equipment you use if you go try this, because there's very conflicting in the data in the literature suggesting that all high flow systems have unique performance characteristics, and it's really important that you be aware. I would argue that the cannula size is the biggest differentiator, but how they're humidified and various things all have some unique characteristics, giving benefits and things that may not be ideal for the patient in front of you. So just be thoughtful, and that's exactly the experience the clinician that I worked with yesterday had. He had tried a larger bore system and said, it didn't blow off CO2 very well, so we tried on with this, and it was a completely different experience. So just be very mindful of your patient, mindful of the type of system that you're using, and I would encourage that you do it, but obviously the computers and robots aren't replacing all of us yet. We still need to be quite thoughtful in how we care. It's not a perfect solution for every patient, but it's a great solution for many of them.
Dr. McQueen, do you have anything to add to that?
No, I agree with everything Dr. Whittle said, and it is a good question. You know, I was a skeptic initially in my neonatal population in the NICU, turned into a total convert just because I had the support of the therapists and the nursing staff that said, you know, we should give this a try. I think it's important for this audience to understand the mechanisms. That helped me a lot when there was physiology behind it. It also helped me to know that I had another set of eyes. So the physios, the respiratory therapists in the US saying, you know, I'm not going to go away. I'm going to watch your patient, you know, for a few minutes while you carry on with rounds or take care of another patient or do something else. So those two things help a lot, understanding how and why the system works, and knowing that they're going to be clinically observed during the start of the therapy. Because as you saw from the trial, the response from the patients who respond to this therapy is typically pretty quick, within the first half hour or so.
Yeah. Let me end the poll and share these results. So we have about 32% who've answered this question.
And thank you to all of our colleagues online who do, if you're able to do the survey for us, it does, we absolutely take very seriously all the things that you include. And for some people in different systems, developing a professional portfolio, the certificate for continuing education, depending on how your regulatory body works, can be helpful for people. So just know that we'll get you a personalized certificate if that's of benefit to you.
Well, Dr. Whittle, it seems like we have some folks who are still hesitant. Are there other studies that show similar results?
Well, there's a large study that we mentioned initially. The first author was Pratik Doshi. It's available on the website for us. That was the initial study from which the subgroup analysis led to this study. So we have seen it there. In addition, our colleagues in Egypt have been very prolific publishers of data in the last few months, and so if you haven't had a chance, they're not sponsored by us in any way, but they are a mighty powerhouse of data. So I would encourage people to have a look at those. In addition, we have a colleague, Gustavo Plotnikow in Argentina. He's just published another paper this month, and he's done a couple papers, again, independent from the company. He did all of his own studies, but he demonstrated CO2 removal as well as decreased work of breathing, and has a couple of really great papers out there. So I would just encourage you, and also look on our website. We try to keep it updated as papers come out, and the newest ones from Egypt and from Mr. Plotnikow out of Argentina aren't there yet, but we're working on a quick summary with a link to them. Again, those are all independent studies showing similar results, none of which were funded or supported by the company.
All right, I think we have time for 2 more questions. What about kids? So it's scary when a kid comes into the ED. How do we think about them?
Yeah, it can be a little scary. I'll jump in and take this one again. I'm a neonatologist, so I don't really take care of the PICU kids as much, although I've done a lot of that in my training. The short answer is the mechanism of action is the same. The non-occlusive interface is the same. And there are data and some trials out there to show that the results are the same, specifically non-inferiority to BiPAP and CPAP, positive pressure standards of care. Just as a teaching point, I can tell you that the researchers at Children's Hospital of Los Angeles have done some nice work on dosing. That is, how much flow should you give for what size patient? And the punchline, the short answer to their studies is that somewhere between 1.5 and 2 liters per kilo per minute seems to be the optimal flow delivery for small pediatric patients, for infants and toddlers up to, say, 20 kilograms or so. So 1.5 to 2 liters per kilo per minute. The more aggressive users tend to start at the high end of that, the 2 liters per kilo. So if you have a 10 kilogram patient in your PICU or presenting at your ED, start at 20 liters per minute. Use the non-inclusive interface. You're not going to deliver any inadvertent pressure. It's just as comfortable for the kids with the warmth and humidification and the non-inclusive interface as it is for the adults. You watch the dyspnea resolve. Once you capture their work of breathing, so to speak, then you can titrate down the flow. So again, 1.5 to 2 liters per kilo per minute, and don't be afraid to use it on the kids. The mechanism and efficacy are the same.
Awesome.
That was a really great point that you just made, Dr. McQueen. I'd just like to highlight it. You said titrate their flow based on work of breathing. So in my practice, I titrate FiO2 by oxygen saturation. I titrate my flow for work of breathing or hypercapnia. And so I think it's really important to recognize we should titrate those independently. In an optimal patient, a type 2 respiratory failure, I bring down the oxygen as quickly as I can for all the obvious reasons about oxygen toxicity. And then consider weaning the flow. But even in a small child, oxygen saturations, FiO2 for work of breathing, or excuse me, flow rates for work of breathing.
Thanks for adding that. Scott, what excites you about the future of Vapotherm? What are you excited regarding innovation or research?
Yeah, I think right now what I'm most excited about is we have an upcoming product for the home, and while that's exciting in and of itself, being able to have a product in the home, be able to deliver therapy to people who are not in the hospital. The piece of that that's most exciting to me is that device is going to be very connected. It's going to have the ability to bring in large amounts of data about the patient, and that's going to enable, I think, a great platform for doing clinical studies in the future, being able to have access to a large amount of data about your patients as they're living with a product in the home, and being able to study how they're responding to different therapies. I think that'll be very exciting.
Yeah, I think that's a great way to end this too. It's looking forward to the future and all the different innovations that you're working on, which is so exciting. Thank you to our panelists for joining us today and sharing your thoughts and the research you've been working on and sharing your experiences. If to those who are attending, please complete that survey. We really do look at every comment. We really appreciate it. And don't hesitate to reach out if you need anything. We had a lot of fun being here today. I'll end the webinar now, but again, if don't hesitate to reach out. My email is ahayes@vapotherm.com. All right, thanks all. Have a good rest of the day.
Recording stopped.